So good afternoon, everyone. Welcome to the Modern Ward Round Collaborative. We've got almost 100 attendees on the call today. People are joining as we speak. We have representation from 16 hospitals. We have representation from the Royal College of Nursing, Royal College of Physicians, the Patient Carer Network, and of course this event is being hosted by ourselves, ECIST. Just a little bit of housekeeping before we start. The event is being recorded, and this enables everyone to be able to watch on playback or watch on demand. So I hope you'll consent to that. And could I ask everyone, if you're not speaking, to keep your microphones on mute. So just to introduce myself, my name's Andrew Rochford. I'm a consultant gastroenterologist at Royal Free Hospital by day, and by night I'm a regional clinical director for ECIST in London, and I'm supported by a fantastic team today. And before we start, I just ask everyone to put their video cameras on or turn them off if that's okay, and then I can introduce the steering group one by one if that's okay. So if everyone turns their cameras off, and then I can introduce you to the steering group. So we have Crystal, if you give everyone a wave. So Crystal's doing all our admin and has been manning the generic email box and responding diligently to everyone's inquiries. We've got Wendy, who's around somewhere. I've got lots of people on my screen. Thank you, Wendy. And we've got Claire in the corner. Thank you, Vince. Lovely. As a positive wave from Vince, that's about as positive as a waving comes from Vince. You'll hear more from Vince later on. And we've got Nick. Fantastic, thank you, Nick. And last but by no means least, we've got my colleague Dan in the corner. So that's the team. And I just, before we start, I just wanted to say a quick thank you to all of them. They put an enormous amount of work in, together with John Dean and Nikki Ashby and Lynn Quinney from the Patient Care Network, RCP and RCN respectively, and we're delighted to be bringing you this collaborative. Now, the collaborative is based on the multi-professional ward round document that was published in January this year through the Royal College of Physicians, and that was an updated version of the original 2012 report, Ward Rounds in Medicine and the Principles of Best Practice. We set up this collaborative. It's being hosted by ECIST and endorsed by the RCP, RCN, and supported by the Patient Carer Network. And it's based on the IHI Breakthrough Series Collaborative, which some of you may have experienced before. This is the first time that we've run one of these collaboratives virtually, so it's a learning environment for all of us. And from an NHS E&I perspective, this is a really different approach to improvement for us too. So for the first time, I think in my experience, we're asking or inviting people to self-assess where they feel they are against best practice, and then we are supporting self-directed improvement on ward-based teams. So this is not a top-down approach, and the delegates we have range from nursing and therapy assistants and support workers to chief executives. So we have a huge range of healthcare professionals and healthcare workers represented in the collaborative, which is really exciting and very unique for us. We are going to support the collaborative with formal education and training events, and Vince will lead on to that later on this afternoon. And each ward and each hospital will be supported by QI coaching, and they are clinical coaches. So it's not pure QI, it's pragmatic QI, but steeped in QI methodology, which we hope will be really supportive. And we're going to be curating learning resources. So for those of you who feel they're more confident in QI methodology, there'll be some more advanced material, but we're assuming a very basic level of understanding, and will provide the IHI backed preparation for everyone. What we really want to achieve in this collaborative is a community of practice. We really would like to support you as participants buddying up together, either on different wards in your own organisation or between different organisations on the collaborative, based on the work that you're doing. We will support that by forming WhatsApp groups if you like. We don't manage these are just being set up for you to use as you will, and we'll put some links in the chat room later on. And we're going to be curating this collaborative through the NHS Futures platform. Some of you may or may not be familiar with that. Again, we'll put a link into the chat room and get that launched by in the coming days as well. And this has two functions. One is it's a resource where we can post things, so the learning events, the on-demand videos, but also we can curate other resources, so reading, articles of interest, and also it has a forum for discussion that you can use and we can answer or not, and people can answer themselves. So we've used this, or we are using this in a number of other pieces of work that we're doing. It seems to be very popular and seems to be a good tool to use. Because this is a new event for us, or a new way of working for us, evaluation is really, really important. We have set up a 6-month program for the collaborative, but actually there's flexibility within this, and we really want to co-design it with you. So your feedback will be sought after every event and throughout the collaborative, both informally through the coaches and formally at the sessions, so that we can design the collaborative around your needs. We want to know what's gone well, what hasn't, and why. We're continually looking to improve ourselves. We will be evaluating the improvements that you make within your trusts. That's part of the programme, but we'll also be evaluating our approach to this to see if we are getting it right and where we can improve. Social media is increasingly important, he says, as a passive user of social media, but we've got a Twitter feed set up on a hashtag MWR21, and I see some people have already tweeted and retweeted around that, and I'm now being followed by people I don't understand or where they live or what it means, but anyway, people are following me, which is nice, apparently. But our reach on social media is really important, so we'll be asking for your support with that, and we'll be supporting the work that you want to do around that. And the final thing from me, just from the housekeeping perspective, is that I've talked about the feedback. We will be asking formally for your feedback from every session. As a thank you, well, it's kind of a thank you. We will be providing certificates of attendance for your revalidation. This is an important part of every healthcare professional's working life nowadays, and by participating in the collaborative, it should form part of your revalidation portfolio. The caveat being no feedback, no certificate. So please do complete the feedback and we will provide a certificate of attendance for each of the learning events that you do. So without further ado, I'm just going to do a quick icebreaker. I've introduced you to the steering group and thank you once again for all the work that they've done. I'd ask everyone to turn off their cameras now, and I'm going to invite the QI coaches. So if you're a QI coach, please just keep your camera on and give a big wave so you can see, so the sites can see their QI coaches. That's it, fantastic, thank you very much. A bit slow, that's some of the QI coaches a bit slower than others, that's fantastic. And then now this is the the slightly dodgy bit. This is not rehearsed. So I'm going to go through the hostels by site and hope that all 16 are with us, because if they're not, it's going to be a bit awkward. So if everyone now turns off their camera, and we're going to invite University Hostels Sussex to turn your cameras on and just give us a wave. Fantastic, that's great. Thank you very much, team. I'm looking forward to working with you. So I'll turn my camera back on because I feel like I'm part of that team. So that's great. Thank you very much. If now invite Lewisham and Greenwich to turn their cameras on and give us a wave. Excellent. Welcome, team. That's fantastic. Thank you very much. Manchester, is Manchester out there? Lovely, fantastic. Thank you very much. And Sandwell, West Birmingham. Great, welcome, team. North Tees and Hartlepool. Fantastic, thank you very much. And as you say, you can see with the photos, we've got a number of people with more than one person on the delegate, so that's also great and to be encouraged. So that's fantastic. Tameside and Glossop. Excellent, well done team. Isle of Wight. Lovely, nice to see you. I presume it's sunny over in the Isle of Wight. I have to say, I've only ever been 4 times. It's always been amazing weather. So as far as I'm concerned, it never rains on the Isle of Wight. Then another one of my teams have got University Hostels Leicester. I think I've already seen Daniela on the call. Lovely, nice to see everyone. Looking forward to working with your team. That's great. South Tees. Lovely, waves from the team, thank you. Bedfords. I have to say, Vivian, Bedford's changed from the last time I was in Bedford.
It's beautiful here today, look.
Welcome, team. North Lincolnshire and Goole. Excellent, good afternoon, team. And we've got University Hostels Birmingham. Lovely. Big waves from the team up there. Thank you very much. United Lincolnshire Hospital. Fantastic. Nice to see you, Anne-Louise. Great. We've got Epsom and St Helier. Oh, fingers crossed. No pressure, Nick. And then Sherwood Forest. Hi, Richard. Nice to see you. Lovely. That's fantastic. So a bit later than hoped, but I'm going to hand over now to Dan, who's going to just present some thoughts to get us into an improvement space and a thinking space before we hand over to John Dean, who's going to properly launch the collaborative. Thank you, Dan.
Thanks, Andy, and welcome everybody. Dan Smith, I'm a respiratory trainee by trade in Nottingham. I'm one of the ECIST clinical associates. Just going to take 1 minute to hopefully get everyone kind of those thinking juices going, just to trigger some initial thoughts from everybody. And just ask that question before we hand over to John and everyone to talk about the document, the modern ward rounds document. The question is, are our ward rounds actually modern? If we sit there and think about how we do our ward rounds on a day-by-day, week-by-week basis, how much of what we do is inherited? How much of what we do is inherited by the environment we work in, our job plans, the tradition about how we teach our junior doctors, the multidisciplinary team members who are available to do that ward round? There's always been some fantastic innovation around ward rounds, and we're lucky enough to be joined by a lot of people who have done innovation. I'm not going to name names, but there are people on the call who have done innovation in consultant job planning around ward rounds, telemedicine, rotas, even really innovative things in terms of checklists for ward rounds as well. But how many of us would truly have taken all those different ideas on board and implemented in our day-to-day practice? I love Andy's phrase today that you've used of community of practice. So hopefully, as we go through the different elements and the different talks today, and we review the document that John's going to present in a few minutes, hopefully those initial thoughts will start to go through your mind of what kind of things have you picking up from the different groups that are on the call, and what bits would you like to truly implement when you do your gap analysis and look for areas of improvement in each organisation. So just a quick thought for the first session. Are our ward rounds truly modern? And I'll leave it there, and I'm going to hand over, I think it's Nick first, isn't it, Nick, to do an interactive session, just to, again, continue those kind of thinking and thought processes going. So nice to meet you all. Thank you.
Thanks, Dan.
If we've
yes.
got any left, let's see if these ones were.
Can we go on mute, please, if you're not speaking? Thank you very much. So this is just a really quick, a number of Mentimeter sessions just to help the session run a bit more interactively rather than us just talking at you for 3 hours. I want you to feel involved in this process as well. So this is the first of 3 Mentimeter sessions which we'll use. So this is where you can answer a few questions for us and give us a bit of feedback as we go. So if you take your camera out, hold it up to get your camera app, hold it up to the screen and scan the QR code. And you should get a little pop-up that says open up in your Safari or whatever browser you're using. If you haven't got a phone with you, you can use the mentimeter.com web address and use the code 73258279 on the top of the screen now. So if you just pop, you'll see a few of you have already put a thumbs up or a heart or a Batman or a thumbs down. Just give a sense of how many we've got in the room. So we've got 110 people on the call at the moment. So we're looking for lots of response from you guys. So there's a series of questions we're going to ask now and then throughout this afternoon. And myself and Claire, who's on the call, will facilitate those. Okay, so a few more seconds now as people log in. Hopefully everybody's getting there. Now, if you don't get a chance to use this QR code, there is one on the agenda which was sent out with the diary invite that went out earlier on this week. Okay, so we've got 40 odd people. So I'm going to move us on to the first question in this particular session. We really just want to get a feel from you guys. What are your hopes and aspirations for the collaborative? What do you want to get out of it? What do you want to see? What do you want to do? What did you join, and what did you feel this would be a helpful piece of work for you? So just type that. It's free. I think this one comes up as a word cloud. So you've got a number of options you can put in there. Just type away, and they'll start to pop on the screen. He says with fingers crossed. There you go. Excellent.
You can enter in as many as you like, I think, as well, Nick, can't you?
Yeah, absolutely. Oh, yeah, it's good. So lots of learning from others.
Change.
Share, yeah. So I think there's a real theme here around collaboration, innovation, learning from others, getting best practice, fixing difficult issues. Yeah, happy staff. That's always really important. How can we remove the rocks in our team's shoes? So brilliant. We've got lots of comments here. We will share all these slides with you after we've finished. So once you've got all the results in, we'll share these around so you can see what everybody said later on this afternoon or tomorrow morning. Still got plenty coming in. So 80 people so far. Brilliant. There's some real standout ones there, aren't there? Okay, so there's plenty more coming there. So I'm going to move us on to the next questions. Really appreciate everybody getting involved with this right now. So I'm going to move us on to the next one, which is a bit more difficult in some ways.
This is really on the flip side to the first question, and it's really, we're interested in finding out about your fears and concerns and any worries that you've got as we go into the collaborative together. So what is it that might be bothering you at the moment? So have a think about that on the flip side to the first question.
This is really helpful for us as a team, and especially if we can offer any coaching around this, is how we can support you in some of these lack of biscuits. One of the downsides, there are a few downsides of doing things virtually, and I think we all recognise the lack of biscuits and cake is one of those.
I think time is really coming through there, and that's something we've heard from a number of teams so far. It's really about how do we protect that time going into the collaborative as well for the teams. Just the real practical stuff that's coming through.
Yeah, and the lack of engagement as well. It's coming out a few times there. Engagement, lack of engagement, disengagement. It's difficult, isn't it, when it's busy, and how do we make time for improvement? How do we set time aside for improvement? Not enough time. Yeah, it's always difficult. Conflicting priorities. Yeah, get all that. It's really helpful for us. This is. So as you're filling that in, the next two questions relate to your self-assessment that you completed, and many of you sent back in. So thank you very much for that. We're asking you just very high-level feedback on your self-assessment. So if you have it at hand, great. If you don't, then just use the questions and put the scores in that you feel are relevant for where you're at the moment. So great, we've got nearly 100 responses. So I'm going to flick us over to the next question. So as I said, this is around your self-assessment you did on your current practice and where you want to be in the future. And one of the things I'd always say about this is that where you want to be shouldn't be all top marks. You know, you have to have a level of realism about this and say that, you know, for some areas we may not get to the top marks. So on your phones or tablets or whatever, you'll see some scores around 1 to 4 around preparation, ward round process, patient-centered and QI. So these may be your actual self-assessment results if you have those at hand, or it may be your own view, your own personal view of where you're at with regard to where you're at now with your ward round work. So that's quite interesting, all quite around the middle area, really. Nothing too amazing, nothing too bad, just kind of okay. So yes, we're up to 50 responses now. It's all pretty consistent.
Yeah.
A bit closer and more patient-centered, and that's interesting to understand. And we'll come on to that a bit later on about how we see ward rounds and how we believe them to be either patient-centered or not patient-centered. QI, interestingly, quite low. Interesting. Okay, so we've still got some numbers coming through. Okay, so I'm going to move us on to the next question, which is around where you want to get to. And as I said before, this is not about getting to 4 on everything. It's being realistic and pragmatic. Where would you like to get to with regard to this collaborative work?
Yeah. Think about the next 6 months. Where do you want to be? Definitely patient-centered coming through. Fantastic. Fairly evenly spread still.
Yeah, that's great. I mean, again, it's an honest assessment, isn't it? You know, it's unrealistic to say we want to get to 4 for everything. But the fact that the patient-centered aspect is the top of your list, I think it's that's what you want to drive towards, isn't it? You know, we'll come on to this later on, but what's the purpose of a ward round if it's not patient-centered? Okay, so we're up to about 66 responses. That's brilliant. So we're going to draw this on to a close now. I'm going to hand back to I'm going to pull this back to the agenda now, and I'm going to close this one down and hand back to Andrew, and I think it's handed over to John. Thank you, everybody.
Thanks.
Yes, thank you, Nick. Thank you, Claire. And we'll share those slides with everyone. But thank you all for your honesty. And we'll be running Mentimeter assessments throughout this afternoon and throughout the collaborative. A really quick and easy way of looking at things. So moving on, and where we're slightly behind time already, it's my fault. It gives me great pleasure to introduce John Dean, Nikki Ashby and Lynn Quinney. So John's from the Royal College of Physicians, Nikki's from the Royal College of Nursing, and Lynn is from the Patient and Carer Network. John is going to give us a 10-minute overview of the Modern Ward Rounds document, and then we're going to open that up into a panel discussion. So John, thank you very much.
Thanks very much, Andrew. And firstly, just to say what an absolute pleasure it is to see this collaborative kicking off. And when we were working on the Modern Ward Rounds recommendations, we recognised that we were describing best practice, and we were describing best practice that was happening somewhere in the UK, but certainly wasn't happening consistently or collectively. So there's no doubt that everywhere recognise they have areas to improve. But what we want to learn through the collaborative is more than is in this document, is the real world experience. I'm sure there will be other innovations and good practice that come through. So this is a really important part of it. So as Andrew said, the Modern Ward Rounds recommendations came on top of the Ward Rounds in Medicine best practice that was published about 8 years previously. but it is really about good multidisciplinary inpatient review, of which ward rounds are a key component. And you'll see on the right that the wide working group that was central to the development of the work, but also we had literally hundreds of examples of good practice coming through. We did surveys which included many thousand clinical practitioners from all disciplines around their experience of care, and we held workshops, particularly with the Patient and Carer Network, which informed the work. And the schema you can see in the middle is where we got to in terms of an overview of what an effective ward round was. And I'm going to delve into this a little bit more detail, I think helps us focus. So the next slide, please, Crystal. So this slide really just says that clearly ward rounds aren't everything that happens on inpatient wards, but we believe that everything that does happen for decision making and for discussion needs to feed in and out of multidisciplinary discussions, which are most of the time focused on ward rounds, or should be focused when the multidisciplinary team comes together with the patient and family and carer to make key decisions. Next slide, please. So we described some fundamentals here in terms of ward round practice, some key principles and some key elements. But when we actually asked people about their experience from different professions, what was really interesting was that there was a dissonance between the different professions of what they were perceiving in terms, and you can see some of that on the slide. So even our definitions and in the questions we asked were probably received quite differently by people. So what's really important, if we just flick down, is that we absolutely understand. Crystal, if we can just move it on, thank you. If we absolutely agree the roles of multidisciplinary team members and their input to ward rounds, and we can get onto that in a bit more detail, but that is, I think, where we all need to start, because there are many different perceptions. Next slide, please. So one of the biggest themes that came through our work was the importance of scheduling. From much of the work and examples, when do the different processes start? Not just the ward round, but the other allied processes. How long does it take? Do staff have conflicting commitments at those times? What can we do to make them timely? And what do we do, very importantly, to reduce interruptions? So I would implore with you all that you think about scheduling and what are the conflicting things around multidisciplinary care on wards that might prevent that from happening as reliably as it could. Next slide, please. So preparation is a key element of modern ward rounds, and there are a number of things that enable that. So we scheme this as starting at the start of the day with a shift handover, might be a bedside handover, and then a whole series of information that comes together to inform a discussion and a decision making and a care plan. So the preparation is absolutely key, and I think it's something that commonly is not done well, although there were some examples of excellent practice. Next slide, please. The actual process of decision making and planning and monitoring on the ward round looks somewhat overfacing, but actually if you do the preparation well, then much of these are answered beforehand, and you can focus in on the key elements around information that feeds into discussion and decisions, and clarifying that, communicating that and documenting it. And clearly, clear documentation is a really important part of ward rounds, and there are a number of recommendations in the document around that. The incorporation of checklists with documentation seems to be many people's experience of the way to ensure that we're covering all of the relevant areas of review. Next slide, please. One of the most fundamental elements that I think steered our recommendations was our workshop with the Patient and Carer Network, and Lynn may touch on this in the discussion. But you can see some of the statements that were made here, and this has certainly changed my personal practice in a number of ways. And I reflect these statements to my team on a regular basis. Next slide, please. So when we think about communication, and of course this is a two-way thing with patients, relatives and carers, we do need to think about that preparation in advance of the discussion and decisions. What is appropriate to have during a multi-professional process on the ward round, and what's not appropriate to have and needs to be at other protected times in other protected, perhaps more confidential environments. But simple things like being at the same eye level as the patient when that communication is taking place can make a fundamental difference to patient experience. Introducing the team, sharing the discussions, involving the patient in discussions should be fundamental. And we've got examples of good practice where there were preparation questions or where short notes were left with patients after the decision making that they could then share with others. Next slide, please. So it's complex decision making and communication that happens during that central part of the ward round, but debriefing and then MDT handover for action afterwards again is fundamental to multidisciplinary working on wards. And again, we've got examples of good practice in the document and in the good practice guidance. And of course, it mustn't finish at that point, but the patient wants to be updated on the progress. The team needs updating on the progress, and further afternoon huddles, and particularly handover into risky times of weekends and nights needs to be important as part of that post-ward round, ongoing MDT working on the ward. Next slide, please. So we do this in various physical environments, and it's important that we pay some attention to the physical environment. Some of us are involved in a couple of weeks' time with some design experts to get further expertise, and we're going to feed this into the collaborative around what we can do in practical terms to address some of these issues. I'm sure you'll all have experienced when your thinking is interrupted by the noisiness, or your conversation is interrupted by the noisiness, and recently how personal protective equipment, makes conversations perhaps more difficult. Is equipment maintained? Is it available? How confidential can we be? And are we in the right environment for confidential discussions? And do we have that space that is protected for thinking time, for documentation, for confidential discussions, or perhaps sensitive discussions? And technology is a big part of modern ward rounds, but it needs to be used appropriately and well. It needs to be an enabler for that discussion, decision making and documentation, and not take over, which is the experience of the research that we fed into this ward rounds review. And simple things like maintaining Wi-Fi, maintaining computers on the wheels, plugged in overnight so they're working during the day, can make a real difference if they're embedded into that schedule of practices on the wards. Next slide, please. Education is a core component of ward rounds. It's something that we have traditionally done in ward rounds, but perhaps needs to be adapted for modern ward rounds in terms of how we do that. But the thing that is not done widely is people's clinical practice and professional practice being trained to take part in this multidisciplinary review with patients at the centre of that. And we believe that developing more widely this practice of skill development in multidisciplinary interactions on the ward centred around ward rounds could be one of the key outcomes of this work and make a big difference for professionals and patients in the future. But inform patients that teaching is taking place on the ward round. Summarise what learning points have been. Make sure this is non-hierarchical so all team members are learning and helping others to learn. Next slide, please. So you've each done the self-assessment, and it'll be fascinating to see these and see how they progress. I'd like to re-emphasise that all the elements that are included in the document are in practice somewhere in the UK, or have been in practice at some stage in the UK. And we hope that the examples in the good practice guidance will help, and we can connect people to those. But you'll have your own examples, and we'll be connecting to you each other during the collaborative. Okay, so I'll finish there. I look forward to the discussion, and I look forward to being part of this over the next 6 months.
Sure. John, thank you very much, and thank you again for your support, both with the working group and with the collaborative. That was a great summary of quite a big document. And I would also add to that we hope out of this collaborative we'll be building our own repository of best practice and case studies from within the people on the call at the moment. So we want to be showcasing best practice from this work. So thank you very much. Now I'm going to invite John, Nikki and Lynn to sort of a round table discussion, if that's okay. I have to confess this is the first time I've done this virtually. It'd be a lot easier around an actual table physically, but so apologies if I stumble my way through it. If I may, John, can I start with you? What do you? We talked about scheduling and other pressures and things. What do you think the real challenges for the delegates will be as they start to try and look to improve their ward rounds in the current climate?
I think the first thing that you have to do is make sure that you have got the whole wider multidisciplinary team engaged at the ward level, and also the leadership of each of those professions. Because some of the simple things like shift start times, conflicting duties, etc., are important, but involve the whole team. One thing we've been working on recently is when meal trolleys arrive on the wards, and whether patients, can be fed at the right time and assisted in feeding, whether there's still other work happening at the same time. And there's some really good examples. So involve the whole team, but make sure that you're engaging that wider stakeholder group that can unblock some of the perhaps more tricky things to unblock beyond the individual ward environment.
Lovely, thank you, John. And on that point, because for those of you who don't know, my clinical area of interest is in clinical nutrition. So we do quite a lot around basic nutrition, hydration and meal times. Nikki, we recently have been revisiting the modern ward, our productive ward series, which is, I was surprised to see it's late 2000s. From a nursing perspective, it strikes me that it's never been more challenging to be a nurse on a general medical ward at the moment. That's coming from a point of ignorance, I guess. But from your perspective and from the RCN's perspective, what do you see as the big challenges?
I think there are many challenges, and as we've highlighted, we recognise the shortage of nursing staff to be able to support all innovations and all areas of practice, and people are working tirelessly to move that forward with the reduction in staff under extremely difficult circumstances at the present time. One of the reasons that we started to look at this as a real collaborative across many different areas as well as medicine was to identify that actually there are skills within each individual group that enter into the ward round that can bring something different and something innovative, and those discussions have really shown with this collaborative approach to developing this how we can address this at a real basic level, as well as looking at the higher levels as well. Those areas that fed back from the Royal College of Nursing's perspective were identification of ward rounds of being learning environments as a collaborative for everybody, looking at the fact that these roles need to be optimised, looking at the fact that we put patients at the centre of those ward rounds and put relatives at the centre of those ward rounds, and I've been watching the chat around that, and that nurses are central to that because they hold a very unique a relationship with our patient group, and they're there a lot of the time and can bring an awful lot of information forward and support the patient to understand the conversations that have been held on those ward rounds.
Thank you, Nikki. That's great, and it is a challenge, but actually we hope that with as part of the collaborative and a part of this work, actually it will enable those discussions and facilitate or improve that multi-professional working, which has, I think, probably become more challenging than ever before. Lynn, can I invite you to comment from a patient perspective? There's some specific questions that we'll come back onto that have come onto the chat, but I'm aware that from a patient perspective, particularly the last 18 months has arguably been more challenging than ever before in terms of being engaged with and engaging with clinical staff as part of a ward round. What are your views on that?
Well, I
I think you're absolutely right. I think there's been an awful lot of really difficult and challenging situations, obviously for healthcare professionals, and but also for patients and their families. And yeah, it's. I think one of the things about being a patient in hospital, frankly, a lot of the time, it's quite boring. And I think there are huge expectations placed on a ward round and contact with healthcare professionals, huge expectations. And so communication, if the communication doesn't work for whatever reason, and obviously there has been, as John referred to earlier, with the PPE, etc., been huge physical barriers to that. But not only are there sometimes physical barriers, but there are also other barriers that get in the way of effective communication. And I think if there's one thing that I would say came out really, really strongly in the workshop and the surveys that John and Nikki did with us as a network as part of producing this, one of the key things that came through was the importance of communicating in that very human to human way, introducing themselves and being at eye level, very simple fundamental things, but they matter so much, and yeah, they can really cut through a lot of the challenges.
Thank you, Lynn. And there's a couple of reflections. I think from a personal perspective, working in an acute hospital, I was at a different trust during COVID, with language challenges and other communication challenges. The amount that I rely on clinically for non-verbal communication was something I took for granted, and when that's taken away because of PPE and other challenges, it made an already challenging situation extremely difficult and extremely stressful. I think the other important reflection for all of us on the call is your comments about the patient's expectations around the ward round and how important it is for them, whereas often I'll be controversial, I guess. I'll see what people say in the chat room, but actually our agenda may be different, and it's just trying to see as many patients in as short time as possible. And maybe we don't stop and think from a patient perspective how that must feel or look. And we're very fortunate to have Lynn and others are going to be running one of our clinical events in July. We hope. We've just got to finalise the details around how we engage with patients and the importance of communication with patients in improvement. So, Lynn, thank you very much for your comments on that. It's lots for us to reflect on, I think, and lots of thumbs up in the chat, which is always a good sign. Can I just I'm going to start with Nikki this time. Can I just ask around the continuity of care challenges? So from a nursing perspective and from a doctor perspective in particular, a ward no longer has one team, it has multiple teams coming in and out at different times. We'll have different team members on different days of the week, times of the day, etc., etc. That's presumably something that the members of the RCN are aware about, feel stressed about. Is there anything that you see that we can do to simplify that, or do we just accept it?
I don't think we should ever just accept. There's always room for improvement. And certainly from the RCN's perspective and from our own personal perspective as part of this collaborative, it's something that we identified loud and proud throughout this, that continuity of care. Somebody's placed in the chat box around 3 or 4 ward rounds occurring at the same time, and that in itself can have human factors implications. Things can get missed, the information could go the wrong way, patients may get missed off from communications, and it can cause delays of care. And to improve that continuity of care and reduce that funneling is vitally important for the patients that will be coming behind, particularly at the present time when they're coming in thick and fast and furious into some areas. The acute admission numbers are huge. So it's about clear communication. It's about identification of role. It's about optimizing the individuals within the team. Each individual brings something unique to the team, but also works collaboratively towards that. And as an education person, this is an ideal place to push forward. The future nurse, future midwife standards talk about collaborative approaches to supporting our future nurses coming through and learning from each other. And that will improve that communication and help to prevent that bottleneck of patients coming through.
Lovely, thank you, Nikki. John, from a medical perspective, do we feel that the sort of the generic competencies that we see in particularly in IMT and foundation year doctors, is that something we need to be levering more in terms of sort of competency-based working at ward level rather than team?
Yeah, very much so. So you know, as we start to, if we actually look in the capabilities, it's all in there in terms of good communication with professionals and with patients, around good record keeping, seizing opportunities for learning. All these things are in there, but do we, I won't say teach them, do we train them? Because training is about learning in practice, reflecting, feeding back, adapting so that you can do that more effectively. So there are examples, and again, in Kent, Surrey, and Sussex, there's much more of this going on around training multi-professionals in those interactions, and they're being seen as multi-professional core competencies of working together. And one of my wishes, and I know Nikki's, is that out of this can come much more of that as just part of the generic skill building we do as doctors, nurses, therapists, etc. So it's a very, very important component, but I don't think we do it well at the moment, other than in pockets.
Lovely, thank you both. Wendy is monitoring the chat. I've been kind of darting my eyes between, but I'm going a bit bog-eyed, I've got to be honest, with a lot of screens on. Wendy, are there any themes or questions that are coming out from the delegates in the chat box?
Yes, I mean, there was a couple of comments around the sort of patient participation, which I think is really important. And Gordon Cordwell had sort of said it's really important to get to know the patient, and I think that's absolutely right. A little bit around how to improve communication with relatives that may not be able to come to the ward round because of COVID restrictions. Is there any sort of tips from the panel, please?
Thank you. So maybe Lynn, can we start with you? Have you got any examples of, or good examples that have come through the patient care network during these very challenging times?
I think I've got limited examples, I have to say, but I have heard people say that in their experience, healthcare professionals have been as diligent as they possibly can be in the circumstances, and used mobile phones, iPads, etc., FaceTime, that kind of thing, as much as possible, and how much that has been valued and appreciated. Because yes, I mean, not hearing anything at all, just being incommunicado, is desperately difficult when you've got somebody that you care for in a hospital bed. So I think, yes, and anything that can be done has been really, really appreciated.
Thanks. I have to, again, on a personal note, I was overwhelmed with the commitment of the juniors in my team, particularly around updating relatives during the height of the COVID pandemic, and the extent they went out of their way to contact people and do their best to update things. It was really, really impressive, and I hope that was reflected with the patient experience. Wendy, any other comments from the chat box?
Quite a lot of chat, and Nicola, you've touched on this, around the sort of complexities of an acute assessment unit, and lots and lots of board rounds, and there's been some really good suggestions from the participants around scheduling, streamlining, maybe having a consultant of the week, etc. But is there any other tips we can give the participants, please?
So tips other than consultant of the week, models to improve that complexity, is that right? And
Yes.
interesting, just I'll see if I can find it. There was an article in the Future Hostels Journal came out this morning about consultant of the week improving stay. John, what are your thoughts on that?
Yeah, I think it does. You know, some of it comes down to scheduling. So do they have to happen at the same time? Does everybody have to be involved in each of them? You know, it's not about everybody being there all the time. It's about the inputs and the outputs and recognizing the opportunities when you need to have the individual patient discussions. And one can't be prescriptive. It does depend on the individual environment. I think the other key bit, and we debated this quite a lot in the working group, was the different role of the coordinator of the ward and the bedside nurse. Yeah, they have different and complementary roles. If you want to know and hear most about what's happening to that patient, then make sure that the bedside nurse is involved. They won't be involved in more than one ward round. They're involved in more than one patient, but they're likely to be in the same ward round. And it's incumbent on all of us. You saw the dissonance in the survey that was on the slide, but mine and many other people's experience is that, you know, some of that is down to doctors, frankly, that we don't sometimes invite that input from the bedside nurse or indeed the HCA or whoever. And then the coordinator's role is a summary and overseeing one. So the coordinator can't be on a 48-bedded AMU on 4 ward rounds at the same time. Who would want them to be? They can't be. It's not right for them to be. So I think that's the other bit, getting that mix right between coordination, communication, and actually bedside review. They're different things. Focus on the bedside review, link it into communication and coordination. Lovely, thank you, John. Nikki, anything to add on that?
I absolutely agree with John. I think that's vitally important, and using the experts that are there. But the role of the bedside nurse is absolutely central to this, because they are communicating with that patient and have something to bring to that ward round. It's very sad that in this day and age, only 61% of nurses felt that they could attend a ward round, or they weren't able to attend 4 rounds at the same time. And often that is the case. And if ward rounds are having to look at innovative ways to be approached without particular individuals present, it's about records, it's about identifying roles, it's about streamlining that. And for me, it's about giving that feedback to the patient. And I'd just like to go back to the point that you previously said about really innovative ways of coming back to the relatives and to the carers. We must also remember that sometimes our patients don't have iPads and find it difficult to, or our carers at home, to access that or understand through sort of computer literacy. So start to approach it with the individual family members. What is the best way to communicate with your family and with your carers to be able to keep that information flowing backwards and forwards? That will move the ward rounds much more succinctly through.
Yeah, I suspect that the wards that are communicating well as a team will be communicating better with patients as well, and hopefully vice versa. Thank you all very much, and thank you, Wendy, for curating the chat, and thank you for everyone who continues to debate in the chat room, which is fantastic. I've got my screens are buzzing. So I'm going to wrap up with one last question for all of you. So this is Nikki, Lynn, and John. I'm just going to ask you in a sentence to sum up, or even a word maybe, sum up your hopes for the Modern Ward Rounds Collaborative. So I'm going to start with you, Nikki.
Oh, goodness, to start. Innovation and development, I suppose. In a sentence, I'm really pleased to see this. I think Ward Round Collaborative, it builds and it grows and it innovates and it continues to develop. So never stand still. That's my look at good practice and build on it.
Lovely. Thank you, Nikki. That's great. Lynn?
Can I use a few words? I'm going to use collaboration, build on the collaborative stuff. I'm going to use co-production and involvement, because I mean, it was great to see the aspiration in terms of earlier on, the patient centre, how people wanted to be very patient-centered by the end of going through this process. And I suppose my challenge would be, then you're going to need patients and carers to be involved in order to be patient-centered. And I think that's really exciting, and I think it's something really a great opportunity for everybody, and particularly for patients and carers.
Lynn, that's great. And actually, if as a result of this collaborative we can co-produce the improvement with patients, then that in itself is almost innovative, which would be fantastic. It's a real achievement. Thank you very much. John, last but by no means least.
Okay, so I'll use two words: spread and sustain. So I'd like us to spread between ourselves the good practice that either there is in these teams, or you'll learn and iterate together, or that we know is happening elsewhere. You'll need to adapt it to your environment. But sustain is also important. So how we're building towards the end, those improvements that we have made, the ongoing monitoring, so they keep on track. We've all been in situations where we've made great improvements and we go back weeks or months or sometimes years later, and it's not sustained, or it's not adapted to the current situation. So spread and sustain.
Lovely, thank you very much. Well, just on behalf of everyone, John, Nikki and Lynn, thank you so much for being part of the roundtable discussion today, but more importantly, thank you for your ongoing support with the collaborative. We're really excited to have you all on board, and for the delegates on the call, I hope you'll be seeing much more of Nikki, John and Lynn throughout the next 6 months. So thank you all very much. And I'm going to hand over now to Dan and Vince, who are going to provide an overview of the programme just before our tea break. Thank you, Vince and Dan. Thank you, everyone, again.
Thanks, Andrew. I'm just hopefully going to be able to share my screen now.
Vince, I've got it. If you want me to, I've got it.
Hopefully that's just come up.
Yeah.
Okay, that's great. So Dan and I are going to spend the next few minutes talking about the learning system that we're going to be using. As Andrew mentioned in his introduction, this is a collaborative, and there are many different types of collaborative that run. This particular collaborative is going to use a method from the Institute for Healthcare Improvement called the Breakthrough Series. So the Institute for Healthcare Improvement is a not-for-profit organisation based in Boston in the United States. And for the last 25 years or so, it's used improvement science to sustain better outcomes in health and healthcare across the world. And it developed the Breakthrough Series to help healthcare organisations, in effect, make breakthroughs in improvements in quality. And the reason for this, and it's the vision really behind the Breakthrough Series, is that the IHI believed that sound science exists on the basis of which outcomes of current healthcare practices can be greatly improved. However, they see that much of this science lies fallow and unused on a daily basis. In other words, there's a gap between what we know and what we actually do. So the Breakthrough Series is designed to help organisations close that gap by creating a structure in which interested organisations can easily learn from each other and from recognised experts in the topic areas, in this case modern ward rounds, and be able to make improvements. So the Breakthrough Series itself brings together teams seeking to make improvements in a particular area, along with subject matter and application experts to select and test improvements and to deliver change. So there's been many collaboratives run across the world using the IHI methodology. Probably one of the best known ones in the UK is the Cancer Services Collaborative, which ran in 1999. And during the 12 months that that collaborative ran, the participating teams tested over 4,500 changes, with 65% showing at least a 50% reduction in time to first treatment. So the collaborative approach can have a really big impact at scale. The collaborative uses a model, and there's a diagram of the model here, and Dan's going to talk through that model in a little bit more detail in a moment. What we have done, though, is because we're delivering the collaborative virtually, we've just adapted this slightly, but pretty much the approach is very much the same, that there'll be learning events, that there will be some action periods in between where you as collaborative participants will be testing out your changes, and then we'll be coming back together to kind of hear about your experience around your improvement journey. So the underlying principle of the IHI Breakthrough Series Collaborative is this principle of all teach, all learn. And this is really, really important, because we don't just want to be as a group running the collaborative, and the experts that are going to be coming in. We don't just want to be teaching you. We want you as collaborative participants to be sharing and teaching each other. And as Dan will explain, there's going to be an opportunity to do this throughout the collaborative. So the collaborative has a number of aims. One of its key aims is really to help move things forward at pace, and it really hopefully gives you the opportunity to maybe take some of those improvement ideas that you've had on the back burner for a while and be able to accelerate those and use the collaborative as a vehicle to take those changes forward. It's a great opportunity for networking and sharing best practice. And it can help shape the way that other projects are delivered in the future. So John's just spoken about spread and sustainability, and that's a really, really important element of the collaborative. It also hopefully lead to, in the language of improvement, becoming part of the culture of your organisation and something that you use every day. And that also it will affect open and effective communication, both in your organisations, but also with your external partners. So I'm going to pass over to Dan now to just talk a little bit about what the collaborative is going to look like going forward over the next 6 months.
Thanks, Vince. Hi, everybody again. So this is just a bit of an outline about dates for your diary, and hopefully a lot of you already have these dates in your calendar. But if not, don't worry. After this event, we'll set up a way of making sure that we have your email addresses so we can add these dates to your diary, or you can share them between yourselves. We're also going to put all of the information from these different sessions on our NHS Futures site, which again, we'll make sure everybody has access to, including the PowerPoints and the recordings for the event. So don't worry if you can't make them, the individual sessions, but we are going to make sure they have variety of times so that they hopefully will match with different people's job plans. So just to go through them here, as Vince said, these are going to fit into that collaborative plan that Vince presented a second ago. The first QI session, which is soon in a couple of weeks' time, that's to focus on the modelling for improvement and PDSA cycles and explain how to utilise them in your quality improvement work. You can see that we're front loading the quality improvement presentation, so the second one comes quite quickly after, just a few weeks later, and that's describing measurement for improvement. So how to interpret and present your data, and that's led by one of our geniuses in the ECIST team, Chris Green, who's an expert on data and data analysis. Then we've got a learning and sharing event, and as Vince says, and the great phrase that Andy used earlier about kind of a network or community of sharing, this is where we want you guys to come and share the work you're doing. Present some ideas of things that you've been putting into practice, and so we're going to really turn the tables around and let you guys take control of those two learning and sharing events. And the third session in November is coming towards the end of this 6-month programme, is about how you evaluate a quality improvement project and how to present that. Followed by the last session on the 16th of December, where we're asking each team to maybe present the work and the improvements that they've made. Next slide, please, Vince. As Vince says, that we've got these action periods throughout the programme, and in between these action periods, we have these events we're calling clinical events, where we have experts in the field coming to present thought-provoking ideas, examples from their clinical practice, or just, as I said, presentations to trigger your thoughts and ideas and to share practice. These sessions are all going to be very different in terms of how they're presented. Some of them will be a conversation style between people like me and Vince discussing a topic. Others will be interactive using Mentimeter and Slido. And again, in some of these sessions, we're going to ask some of you guys to present to us or to share your learning with the team. And we've got a range of topics which we try to match to the modern ward rounds document. So that includes what the ward round environment looks like, and we've got experts in the physical environment and human factors and ergonomics coming to present that. We've got patient representatives, experts like Lynn, who was talking on the call earlier, and colleagues to come and do the patient engagement session. The best practice before, during, after the ward round, we're envisaging that to be more of a Q&A session, so it becomes more of a conversation rather than us presenting as a team towards you. And then other sessions about high risk times, such as out of hours and handovers. We've got experts who have implemented out of hours team, managed digital innovation in terms of putting in software to do task management and things out of hours. So hopefully a really broad mix of sessions. And as I say, all of these will be available for you guys to access through the NHS Future site, and hopefully to join in on the sessions as well. But thank you, Vince. I'll hand back over to you.
Thanks, Dan. So as Dan just alluded to there, we will be running some quality improvement sessions, and after the break we're going to give you a little bit of a taster of what some of those sessions will look like. As Dan said, we're going to front load the collaborative with some of the tools that we're hoping that you'll use throughout the collaborative, and we've got some good sessions coming up, as Dan said, from Chris Green, and also from a couple of our colleagues on the call, Nick and Wendy. The model for improvement, I'm sure many people are familiar with, the Plan, Do, Study, Act cycle, and that really is the main improvement tool that the IHI Breakthrough Series uses. So we're hoping that you'll be able to kind of use that in the action periods between the learning events, and that you'll be able to kind of bring that back to those sessions that Dan spoke about and be able to share your experiences around your improvement journey. Now, the collaborative itself is not just about sort of implementing modern ward rounds. What we're hoping is you as collaborative participants go beyond the collaborative, so that what we're looking for is for you to not only present the impact that your changes have made, we want you to help us analyse and evaluate how well we've delivered the collaborative, so we can shape future collaboratives. And certainly at the last learning event, and there's a QI session tied into this, is we want you to be sharing your thoughts and ideas around not only how you're going to spread the improvements that you've tested during the collaborative, but how you plan to share your experiences and your knowledge that you've gained throughout the collaborative, both within your own organisations and with your system partners. So it's going to be a very packed 6 months. We really hope that you enjoy this. There's certainly the QI sessions. We've got some great speakers lined up for those. There's some brilliant experts that are going to be involved in the clinical events. And obviously, also alongside that, and I'm very conscious that some of you as participants have already met your QI coaches from the ECIST team. But if you haven't, I would encourage you to make contact with those in the not too distant future, because they're going to be able to support you throughout the collaborative And because we want you to help shape the collaborative and what we deliver, what we're presenting today is just sort of, if you like, a very broad framework. There are lots of things and there's lots of expertise that we can bring into the collaborative as well, but we want you to tell us what you want from the collaborative. So if you want specific sessions, you don't think we're putting stuff on, or you're feeling that there's things that are not working, do let us know. So thanks for your time. I'll be back later to talk about one of the QI sessions. So I think it's back to Andrew now, hopefully.
Well, thank you very much, Vince. Thank you, Dan. We're actually coming up to a tea break and a comfort break. But before we go, we've got a second Mentimeter session with Nick and Claire. So over to Nick and Claire, please.
Thanks, Andrew. Yes, this is our second Mentimeter session. For those of you who've joined partway through, if you wouldn't mind to log into Mentimeter now using the QR code in front of you. Most of you should have stayed logged in, so that should be quite easy and straightforward. So this session, we've just got 3 questions for you, and we'd really like to explore how confident you feel about ward round best practice and improvement. Okay. Nick, could we go to the first question? Thank you. So our first question is, what are your confidence levels within ward round best practice at the moment? So do you feel like you're expert, you've got a fair amount of confidence, you know a bit, or you feel like a complete novice? Okay, oh, not many experts there. Okay, fair amount, that sounds good. Quite a bit of modesty probably. But some complete novices, that's absolutely fine. That's brilliant. Okay. Most people, fair amount of confidence at this point in time. That's great. How we do
this is really around best practice as well, isn't it, Claire? Not just about, you know, you're all very familiar with what a ward round is, but do we know about some of the best practice out there? How much we maybe have read the guidance from the RCP? So really good. So a couple of experts. Maybe we'll hunt out who the experts are, and we may get them back to come and speak, which will be helpful. It's always good to have genuine experts out there as well. Excellent. Okay, so we've got to about 60. So we're going to move on to the next question. So that's a really nice return. So we're going to ask more specifically around quality improvement practices. We asked this around your self-assessment, and this was down the low end of the scale. So what's your, as a team, as a group, what's your confidence levels around using quality improvement in your daily practice? Not just theoretical knowledge, but actually using it in practice. Excellent. So lots in the middle. I think there's quite a lot of people with a bit of knowledge. I think that's what we see with quality improvement. And there's somewhere, you know, there's some real experts out there, which is really helpful.
Right.
The nice spread across the middle there, yeah. So again, it's about how you feed off each other, and hopefully some of the sessions that we put on will be helpful. And if there's other people out there across the whole network, and one thing that's really key on here is this: we've got 100+ people on this call. So how do we develop a network of people across the country who are speaking to each other, not just speaking in your own circles? Okay, brilliant. So I'm just going to move us on to the last question.
Thanks, Nick. So the last question is just around, when was the last time you undertook ward round improvement work? Okay, between 3 and 12 months. Some people have never done any, and that's fine. That's good. So it's a real new area of focus for improvement as well, which is great.
This is really helpful for us to understand where you're all at in different parts of your journey as well. As we've said, there's 15 organisations participating in this, and each one of those will have 2 wards. So, you know, with 30 odd wards, that we want to know where you're all at, and there'll be a whole spectrum of levels of confidence around this. So it's good that we get an understanding of where we're all at. And again, those ones who have put in about the last few days, interesting just to maybe just pop in the chat box if you can in a short summary. What is it you've been doing in the last few days, just to give us an idea of the more recent improvements that you've made. Okay, so we've got up to nearly 70 again. So that brings us nicely towards the break. Andrew, I'm going to hand back to you to wrap us up.
Lovely, thank you very much, Nick and Claire. And it's really interesting. So we thought we would have a mixed bag of knowledge, skills, and attitudes on the course, which is brilliant. I would hope that we would be able to move everyone to the left-hand side of those graphs, and particularly for those, because this is an IHI collaborative, there is ample opportunity for everyone to become experts in QI based on the knowledge that we can support and the learning, and also the practical experience that you'll get doing the collaborative. So that's really exciting. We're a couple of minutes ahead of schedule, which is really good. And so what I'd suggest, we've got 20 minutes. So if you take a break now, if you turn your cameras off and leave everything on mute, if that's okay. And we're back in the room at 20 to 4, where we're actually going to essentially give our first QI session with an overview of QI methodology, starting with Vince. So we'll see you back in 20 minutes. Thank you, everyone. Right, good afternoon, everyone, and welcome back. I'm gonna start with an apology. I've been eating humble pie with my cup of tea in the break, so I must apologise to the team at Luton and Dunstable, which is a real personal pity, because I started out my medical career at Luton and Dunstable as a house officer many years ago and had a fantastic time. So to start the second half, could I get everyone from Luton and Dunstable who's still on the call to turn on their cameras and give us a big wave, please?
Well, that's why I'm ringing, because
Lovely, thank you very much, Esna. Thank you. Great, thank you very much indeed. Right, so we're into the second session now, and in the first Mentimeter test, questions we raised, we asked about your hopes and aspirations, and big features of that were about improvement, best practice, efficiency. One of the common things about the hopes and aspirations and the challenges and concerns was around engagement. So the next session is going to, I hope, going to give you a good taste of what's to come. We've had a really enthusiastic start to the collaborative. Thank you for everyone who's tweeted and retweeted. Thank you for all the comments in the chat box. Please keep them coming. I'm now going to hand over to Vince, who's going to take us through the model, so an introduction to quality improvement, and then we're going to go through some of the QI methodologies before Q&A session in just under an hour's time. Vince, thank you very much.
Thanks, Andrew. So I'm just going to share my screen. So as Andrew's just said, this is the first of some very short QI sessions as a bit of a taster to the longer QI sessions that we're going to deliver throughout the collaborative. So I'm just going to start off by just sharing a few thoughts on what is quality, how can we improve quality, and what does quality improvement mean? So according to the Health Foundation, there's no single definition of quality in healthcare. However, healthcare systems worldwide have committed to monitoring and continuously improving the quality of the care that they provide. In England, the NHS is organised around a single definition of quality, which I'm sure many of you are familiar with. And this is split into three elements. The first is that healthcare is safe and avoids harming people from the care that's intended to help them. Secondly, that healthcare is effective, providing services based on evidence that produce clear benefits. And thirdly, that healthcare delivers a positive experience, and this positive experience is split into two parts, and that is that healthcare should be caring, that the staff involved treat people with compassion, dignity and respect. And the second bit is that healthcare is responsive and person-centred, and that services respond to people's needs and choices and enable them to be equal partners in their own care. This definition also states that care should be well led, so that providers are open and collaborative internally and externally, and are committed to learning and improvement, that it's sustainable, meaning providers use their resources responsibly and effectively, providing fair access to all and according to the needs of their population, and that healthcare is equitable and care is provided that doesn't vary in quality because of a person's characteristics. All these dimensions are important and are often complementary. However, there can be tensions between them that need to be balanced. Therefore, all stakeholders' views need to be considered when identifying improvement priorities. And this is something that we're hoping and encouraging you to do, to involve as many people as possible in your collaborative projects that you're going to be engaging in. So how can we improve quality? Well, there are several factors that are required to drive and embed improvements in healthcare organisations and systems. Three of the key ones are leadership and governance, and this requires senior leaders to play a critical role in creating a positive organisational culture, which has consistently been associated with improved quality outcomes. And they can do this by placing improvement at the centre of organisational strategies and fostering an environment in which frontline teams feel safe to question existing practice, report errors and try new methods. Good governance arrangements will also ensure that there are processes in place that identify quality issues that require investigation and improvement. A second factor that's important is developing an improvement culture and a set of behaviours and skills. And this can be achieved by building the improvement skills and knowledge at all levels. And we're hoping that that's what we're going to do with some of these QI sessions throughout the collaborative. Giving everyone a voice and bringing staff and patients and service users together to improve and redesign the way that care is provided. And we have got an optional session that we can put on if people feel that that's something of interest around co-design. And another factor that's important is around having flat hierarchies that ensure all staff have the time, space, permission, encouragement and skills to collaborate and plan on delivering improvement. And the third factor is the effect that the external environment has in terms of improving quality. And this can be achieved through policy, through regulatory bodies such as the CQC, and the government in terms of ensuring that health and care services are appropriately resourced to deliver an agreed standard of quality. So my final slide is to just look at what does quality improvement involve. So quality improvement draws on a wide variety of approaches and methods, and I'm sure many people are familiar with things such as Lean, Six Sigma. We're going to be using something called the model of improvement, which we mentioned earlier, and Nick and Wendy are going to do a session on next. However, all these approaches share some underlying principles, and these include identifying quality issues, understanding the problem from a range of perspectives, with particular emphasis on using and interpreting data. And Chris is going to give us a bit of a taster on that, and then we've got a session on July the 6th where he's going to go into a little bit more depth around that. Developing a theory of change, identifying and testing potential solutions using data to measure the impact of each test, and gradually refining the solutions to your problems or your issues, and implementing the solution to ensure that the intervention is sustained as part of standard practice. And again, we've got a QI session in November that focuses specifically on that. To be successful in implementing change, it's important to create the right conditions for improvement, and we're hoping that that's what the collaborative is doing in terms of developing modern ward rounds. And these conditions include the backing of senior leaders, supportive and engaged colleagues, patients, and access to appropriate resources and skills. However, quality improvement isn't just about the technical aspects, such as applying tools and measuring changes. It's also about people and the way in which the team and the people leading the improvement work together, and how they communicate with others who support their need is likely to have a profound influence on the success of your improvements. And the relational aspects of quality improvement include involving and engaging staff, co-producing improvement, building effective teams, and collaboration. And we're hoping some of the sessions and some of the and through some of the coaching that we're able to support you with this. So finally, quality improvement is about giving the people closest to the issues affecting care quality the time, permission, skills, and resources they need to solve them. It involves a systematic and coordinated approach to solving a problem using specific methods and tools with the aim of bringing about a measurable improvement. And we're hoping that the set of quality improvement tools that we're going to share with you and the collaborative itself will enable you to move forward with your quality improvement initiatives and make some sustainable changes going forward. So I'm now going to pass over to Nick and Wendy, who are going to talk about the model for improvement.
Great, thanks, Vince. That's really helpful introduction to some of the background and some of the theory, particularly around quality improvement. I think, as Vince mentioned on this session and earlier on, the model for improvement really is the basis and the foundation of the IHI Collaborative Breakthrough Series model. Using this model to apply those changes in a very much an experimentation, testing kind of way, really is the bedrock and the stable foundation for good quality improvement. I've used this for years now, and I think it really is about how you can bring out multiple ideas, engage with all the teams, not having all the ideas held by one or two people. This is about encouraging a crowdsourcing approach to improvement, but really with a clear sense of direction. So I'm going to talk through the model. Many of you will have seen this. I think most of you will probably come across it in one shape or form or another. Many of you have probably seen the bottom bit, the plan, do, study, act cycle, which some of you may know as the Deming cycle or the other ways. But the model for improvement incorporates that with the three key questions that you'll see at the top. And this is what I want you to think about as you think about your changes, think about your improvement. Each of your tests of change, each of your improvement ideas should be accompanied by each of these questions. So what's the aim? What is it trying to accomplish? And it may not be the overall aim. It may be just a small test, a small change. I'm going to hand over to Wendy in a moment. She's going to talk through some examples. But what's that? It could be just that small change you want to introduce, that one idea. Then how will you know that the change is an improvement? What's the measurement you're going to include? This is the bit that will often get missed out because sometimes it's just too difficult. The metrics aren't always available, and we may have to do some manual counting to get the measurement. But how often have you seen a change introduced with no measurement aligned to it, and 6 months down the road you can't really get a sense of has this made a difference or not? You want to be able to see that have the changes that you made, have they made a difference? Similarly, you want to find out if they're going in the wrong direction. So is it meeting the aims and the objectives? So are the metrics changing? So if you don't have a metric, you can't understand whether it's making a difference or not, and if you have to tweak it, and when you move on to the actual application, whether you need to change direction slightly, or even sometimes abandon the idea altogether because it just hasn't worked. Sometimes you just have to be brave and accept that failure sometimes is as good as a learning opportunity as other aspects. And then what you do, once you've got your aim, you've got your measurement, you know where you're heading, what direction you're going, then you can crowdsource as many ideas to understand what are the changes that you can make that will result in that improvement. And as I said before, this shouldn't be held with, the power shouldn't be held with individuals, in senior leadership positions. This should be all your teams across the whole MDT. The many ideas you can harvest, the better. This really does lead to really great staff engagement. People feel involved in the work, and at the end of the day, the people who do the work understand their job better than anybody else does. So make sure you utilise all the people in your teams. And then you move on to the more familiar bit, the rapid improvement cycle of Plan, Do, Study, Act. And we're great. Something we're really great within the NHS is doing lots of planning and lots of doing, but we're not great at doing the study and the act. So as you think about your improvement journey, how are you going to build in an opportunity to study and then to act on that study that you've taken place? So plan the work. How are you going to communicate it? Who do you need to talk to? What are you going to do? When are you going to do it? Then you launch into that period of doing and testing it, and you'll agree how long you're going to do that for. And these can be, and some of you on the call will have been part of some of my rapid improvement events, and we're testing things in hours, not days or weeks or months. So these rapid improvement cycles can be very quick. So how long are you going to do it for? And then what are you going to do to study? How are you going to come back together to understand, have the numbers changed? What have we learned? What's the qualitative and quantitative data that we can pick up? What's the patient experience? What's the staff experience? Understand truly what difference that change has made, and how you can alter it or tweak it to move forward, which is the act bit. And then you go again. You go into that plan, do, study, act cycle. So as familiar as this model is, and a lot of us are familiar with it, it's about understanding the detail behind it and sticking to the principles behind it and applying the different elements. And often what we see is that it's given a cursory glance, and we go into what we see as plan, do, study, act cycles, but what we're only actually doing is it's an idea that's been generated by an individual. We haven't got any metrics attached to it. We're gonna do some change, but we don't look to see if it's made any difference. So I'm going to hand over to Wendy, who I think has got a really great example of where this model of improvement has been applied in clinical practice. Wendy, over to you.
Oh, thank you, Nick. So the next slide, please, Nick. I think probably the example I'm going to show you is similar to something that Gordon Caldwell must have done, because it is involving patients. So this is a real example of work I did when I worked in Swansea. And, we wanted to ensure that all patients staying on the ward, and it was an acute assessment unit, are involved in discussions and decisions during the ward round by midday. Now, it's really important with your aim that it is specific, and that it is clear and it means something, and also it's got some measurement in there. So it's specific for the cohort of patients on that ward, and there is a measurement in there that there's a time scale to it as well. So this is because we want to address people's concerns. We want to make timely decisions that can be actioned in the same day, and we want to find out about the person, their choices and their needs, and that the patient and relatives have understood the situation and have been able to ask questions, and it maintains that control and that people feel they're listened to. Thanks, Nick. So after the aim, you're going to look at your measures. So for this, similar to as Gordon's mentioned in the chat box, you're going to see there needs to be one person at eye level with the patient during the ward round, and you can count that. If you've got a ward of 28 patients, then hopefully you would see that 28 times. And the patient is left with a short note explaining the outcomes of the discussions And going back to John's talk earlier today, we talked about that is a really good enabler for people to understand, and that patient and relatives are able to answer the 5 questions or 4 questions, whatever you use in your organisation, but so the patient can understand, you know, why am I here? When will I be leaving? What is the plan and what needs to happen today and what needs to happen so I can get home? And the patient experience and feedback is really important. We know that many complaints occur because patients feel they haven't been listened to. And you can measure that from doing, you can use a baseline now and you can measure it as an outcome. And that the ward round start and finish times also is a really good measurement. Thanks, Nick. So ideas on how you could achieve this. So again, working with your team and working with lots of people, just get those ideas out there, and no idea is stupid. You know, let's all have a go. Explain to patients on admission their role in the ward round and how important that is. You could agree the roles prior to the ward round, so you might have somebody providing the eye contact, somebody writing the note. You might alternate, you know, you might change that role around from doctor to nurse or whatever. And you have a simple pro forma, so you might have a pro forma that's already, you know, there, which says, you know, today on the ward round, and then you can write a couple of things. And that the relatives and carers are invited, you know, at the patient's request. They may not want them there, but actually they're invited to the ward round because you know it's going to be finished by midday. So actually you can invite them for that morning. Thanks, Nick. That's the end of our session. I hope that's useful, but as Vince has explained, there are going to be QI sessions throughout the collaborative. So we will absolutely expand on these ideas, and you can always ask your QI coaches for resources and tools and approaches. So I'm going to hand over to my colleague, Chris Green, who's going to do a short session on measurement for improvement. Hi, Chris.
Hi, Wendy. Hi, everyone. Hope you're having a good afternoon. So my name's Chris Green. I'm the head of informatics for the Emergency Care Improvement Support Team and work with many of the colleagues on the call today. As Wendy alluded to, I'm just going to kind of give you a brief kind of run through over kind of what we do within the analytical function of the team and also some of the products that you have available to you. So I'm just going to pull up the presentation, so bear with me 2 seconds. And I hope everybody can see that now. So I'm going to start with just by keeping something nice and simple, and it's 2 phrases that I often use, and I don't share many other characteristics with Einstein, unsurprisingly. However, I do really share these quotes, and the first one is genius is making complex ideas simple, not making simple ideas complex. And the second one is if you can't explain it simply, you don't understand it enough. And I was on a course, I'll just put this into kind of context. I was on a report writing course a few years ago with the Press Association, and they explained something to me really nice and simply, unsurprisingly. And that was that if you want to see a really simple way of explaining a story, go and have a look at how tabloids report on difficult situations. Now, I'm not going to talk about the whys and wherefores and the differences between tabloids and broadsheets, but what they explained it to us was that broadsheets go into it in a phenomenal amount of detail, but what the tabloids have the ability is to be able to get across a very complex story and it being able to be understood by the vast amount of people. And it really kind of stuck to me, really, that the NHS is awash with data, and I dread to think how many dashboards there are looking at everything to do with NHS patient care. And that's both from a kind of a patient safety, quality, measurement, and a performance perspective. But I think the thing for me really is to try and keep it as simple as possible so that everybody understands that, not just a data person, which I classify myself as, but everybody throughout the entire NHS. And I used to really value my time with, I wouldn't consider myself to be a traditional analyst. What I love to do is actually spend time with other people in the organisations, whether that's clinicians, whether that's operational managers, to understand what they do, how they do it, why they do it, when they do it. So that when somebody asks me a question about, well, demand's going up in our urgent care centre, can you provide some analytical explanation as to what's happening, I knew exactly what they meant and was able to take it even further. And that kind of goes down to the 7-step approach for measurement for improvement. And we kind of really stick to this approach because, and I think Wendy and Nick were both talking about this, was that it gives you a very clear understanding of the steps that we need to go through. So deciding your aim, what is it that you actually want to achieve? What is your objective? Choosing those measures, and it could be relatively simplistic. So it could be something like, we want to reduce the number of patients with a long length of stay. Defining your measures about looking at inclusions and exclusions if you want to kind of take out any other type of patient that might be in there for a prolonged period of time. And then really importantly, going through the collecting the data phase, analysing, presenting and reviewing measures. And this is a real cyclical pattern. And that's something that we'll be picking up with in the session in a few weeks' time. But the thing to do is, do you really know your processes on your wards? You often see this in branding and advertising, which is new and improved. Well, the great thing is it can't be new and improved, because if it was new, there was nothing before to compare it to, so therefore it can't be an improved. And if it was improved, it had to have been something before. So just be aware of all of the processes which go on your organisation and on your wards to work out what has been done in the past, what's likely to have. Visualising data is also critically important. There are so many different charts that I have seen, and many people will have seen. There's just line charts which are just, dozens and dozens of line over it, things like that. But what you want to steer clear from, particularly in the measurement for improvement phase, are pie charts. And we've seen all sorts, including the 3D exploding pie chart, which is absolutely fantastic. And I'll just give you an illustration as to the only best way to use a pie chart. And that's this: the proportion of pie that I've eaten and the proportion of pie that I have not eaten. Steer clear from pie charts. They have no purpose in the measurement for improvement perspective whatsoever. But an SPC chart or a statistical process control chart does. It's really at the heart of measurement for improvement. What it does in a nutshell is it moves data away from being crude data into something like intelligence. Okay, so data is just a number. We want to move it to information, which would just be putting it onto a time series graph, and then moving it over into intelligence, which is actually highlighting things which are statistically significant. So you can see, for example, on this graph, we've got the black line being the number of patients who have had a long length stay of more than 7 days or 7 days and over. The blue dots signify that there's been improvement in special cause variation. A red dot indicates special cause concern. But what it will also do is also move you towards the action phase of measurement for improvement. So actually just moving away from the normal variation to well, this is statistically significant. We need to have a look at this into more detail. So realistically, taking the process from data, moving it into action. So the ECIST UEC dashboard, which is a dashboard which comes out, it was on a daily basis when we were under significant pressure. Now, don't get me wrong, I know there is still significant pressure, but I'm talking about kind of the early stages of the calendar year. It did come out on a daily basis. It now comes out on a Monday and a Thursday. It can be available to anybody, but it's not a prerequisite for any type of work that you might be achieving. But what it does in terms of statistical process control is it does everything for you. So, for example, on the grid, which is the first part of the dashboard, what you'll see is some demand metrics over on the left-hand side, process metrics and some outcome metrics. And for each of those boxes, it will indicate whether something is within normal variation, which should be highlighted as a grey square, a negative special cause concern, which is indicated as a black circle, or a special cause improvement, which is indicated by a green diamond. And what it allows you to do is it allows you to focus on the areas of interest that you might want to focus more attention on. So, for example, for this organisation, they would say, well, we're doing really, really well in terms of our critical care occupancy and a reduction in our long length of stay patients at the same time as demand is increasing. The graph will also show you other areas, and what we can see on this particular graph is that not only will it indicate the black line, which is the number of patients who are occupying a bed. But what you'll also see over on the far right-hand side is the grey line. And the grey line will actually use historical activity to forecast for the next 7 days. There are some things which it will forecast or predict. There are some things which it won't. So it will predict demand coming through the front door, A&E attendances, walk-ins, number of patients arriving via ambulance. It will predict occupied beds and long length of stay, but it won't predict things like process measures. So it won't predict time to treatment, the 4-hour performance, for example, and would never go down that route of trying to predict the 4-hour performance for various different reasons. There are pitfalls, though, however, and so statistical process control charts are fantastic information for improvement, as long as there is relative stability within the data. And so this, for example, is a poor use of SPC, so I've done it just to kind of prove a point, and I've used it for the COVID beds occupied. So we've all seen the data which comes out via various different means, but because there is such significant variation from the minimum point to the maximum point, you might expect that the upper and lower control limits would be significantly far apart. But because there is actually little change day by day, you can actually see that the upper and lower control limits are very, very narrow. And so, for example, almost every day is either a special cause concern or a special cause improvement. We will be going through this in much more detail and providing additional documentation where necessary. We're also seeing significant variation trust by trust. So here, for example, we've got on our scattered plot, every grey dot is every trust in the country. And what we can see over here is that there are some organisations that are seeing a significant reduction in their beds occupied. So on the horizontal axis, we can see some organisations have managed to reduce their beds occupied by 20, 25, 30%. But there are some organisations which actually have even seen an increase in their occupied beds, particularly illustrated by point number 13, trust number 13. And what we want to be able to do is we want to be able to link different organisations. This isn't a performance thing. This is an improvement area to kind of go, well, what are trust 13 doing that trust 11 or 5 are not doing, or vice versa. So we'll be actually using the data that we've got and the data that we are easily able to obtain to help us to work with different organisations. So that's it from me. My email is chrisgreen@nhs.net. I'm also on Twitter, and I'll now hand over to the next presenter.
Yeah, thanks, Chris. I think it's me next. So hi, everybody. My name is Pete Gordon, and I've been asked to talk about social movements, so a little bit different. And it's I'm going to talk about how do you get your changes in the hands of the many. Can you just give me a shout if you can see the slides?
Yeah, good, Pete. Thank you.
Yeah, great. Okay. So as I said, my name's Pete Gordon. I'm head of emergency care improvement with ECIST. Just going to talk about how you win over hearts as well as minds. I mean, one of the brutal facts is a lot of change initiatives fail. So it's really important, if we want people to do stuff, to take action, we connect in with their values and their emotions as well as their logical brains as well. And typically what we usually do is we start with what rather than why. Let me explain that. For Simon Sinek, who's a very well-known improver, he talks about the golden circle, and typically most organizations know what they do, or teams know what they do, and some know how they do it. So you'll all be thinking about your ward round processes, but very few organizations or teams know why they do it. But if you start with why rather than what, the influence is much greater. And let me explain a little bit more about the why. So the why is, what's your purpose, your shared sense of purpose here? What's your cause? What's your belief? Why does your organization or team exist? Why do you get out of bed in the morning? Because the thing is, people don't buy what you do, they buy why you do it. And here's an inspiring example. It may be slightly over the top, and I'm not expecting any of you to be like Martin Luther King, but when he stood in Washington in the 1960s, he didn't stand there and say, I have a project plan. We all know what he said. He said 4 words, I have a dream. And, that's a really good example of how one individual, creating a social movement. And what I'd advise you to do, as well as looking at the data and creating your plans, is think about, well, what's the compelling stories, because they engage frontline teams, and remember, people don't buy what you do, they buy why you do it. So for example, here we've got some data, research study, 48% of people over the age of 85 die within 1 year of hospital admission, which it resonates and it's factual. But I really like the phrase that a couple of phrases that Brian Dolan, who's a really good mate, he coined when he was working in New Zealand. And if you had 1,000 days left to live, how many of those would you choose to spend in a hospital? And whilst he was working in New Zealand, he also coined the phrase that patient's time is the most important currency in health and social care. And I often think about this when I think about my elderly parents when they've been in hospital. Waiting isn't passive for them. And when I think of my son Alfie, who's now an adult who requires 2-to-1 care 24 hours a day, waiting isn't passive for him. Waiting isn't passive for us as his parents. And I love this tweet by Simon Weldon, who's the Chief Executive of Northampton and Kettering. Feedback from the relative of a patient that talks to the importance of time. When you have a life-limiting illness, each moment becomes precious. Waiting a minute feels like 10. Waiting 10 minutes feels like half an hour. And waiting half an hour feels like an eternity. And the work you're about to embark on, the brilliant work with your ward rounds, is, for me, I think to myself, imagine all that time that you'll have saved for patients and their families. And Chris touched on this a little bit in his last talk, but whatever you do, this phrase, if you can't explain it simply enough, you don't understand it well enough. And, for sure, your teams also won't be able to understand it. So wherever you can, don't make it simplistic, but try and make it as simple as you can. And when you're embarking on, these change efforts, people are going to say no an awful lot. And this is a technique I use a lot, and it's called going for no. And it comes from sales. And the evidence is that 2% of sales are made on the first contact, 3% on the second, on the second. But if you can get past 5 no's, 80% of sales are made on the 5th to 12th no's. So expect people to say no, but don't give up. Reframe your approach. And this is something I do a lot. I'm not asking you to just stalk people, but think about going for no, because once you get past the 5th no, your chances of success will go up. And often in the NHS, we often see, so my background's in nursing and operational management and improvement. And often when I was in operational management, it was a bit like being a fire officer. You're putting out the latest fire, but really try thinking a bit more like a farmer. Rather than somebody who's putting out fires the whole time. So what the farmers do, they don't shout at the crops. They don't blame the crops for not growing fast enough. Well, that doesn't work. They don't uproot the crops before they've had a chance to grow. They choose the best plants, the processes and people for the soil. They irrigate, they fertilize, that the provision of motivation. They remove weeds, those constraints that get in the way of you doing the right stuff. And they realize that outcomes aren't predictable. And of course, sacking the farmer probably isn't going to help the crops grow. So thinking a bit more like a farmer. And then also when you're trying to get movement and get your teams really engaged, is this thing about being incredibly civil to people and decent. And this is the work of the brilliant Dr. Chris Turner, who's in himself has created this social movement around civility saves lives. And the data on when you work in an environment which lacks civility is really quite stark. 80% of people lose time worrying about it. 48% reduce their time at work. 25% take it out on their customers and patients. And I'm sure we've all worked in environments where it lacks civility. So when you're going about your improvement efforts is, really thinking about this. And when Google did years of intensive analysis, and what they found to really great teamwork was really simple. It was being nice. And then there's also something about self-efficacy. So this is the perception of one's ability to perform a task successfully. So this isn't arrogance, it's a belief. This famous quote by Henry Ford, if you think you can, or you think you can't, you're right. There's a really positive relationship between the self-efficacy beliefs and the ability to facilitate change and get good outcomes. So a belief in what you're doing is really important. And whatever you decide to do, there's never a right time. The conditions are always impossible. It's summer, it's the holidays, it's Christmas. is, you know, making a start is important. And I love this 2 levels down rule by Paul Plesek, who's a really well-known Canadian improver. So if you think your idea is going to take a year to test and implement, consider what you could achieve in a week. If you think it will take a week, what could you achieve in an hour? So maybe think about using that 2 levels down rule. And, you know, perfect's the enemy of good. So whatever you're trying to do, don't try and make it perfect. If you know, think about this set of stairs, you don't have to see the whole staircase. Just take the first step. I don't know about you, but for me, there's a lot of rules in the NHS which are absolute, I'll mind my language here, but absolute nonsense. And I think some of these rules are there to be broken as long as they benefit teams and patients and their loved ones, but obviously not encouraging you to break the law. And I love this tweet by Simon Sinek: a small team committed to a cause bigger than themselves can achieve absolutely anything. And of course, along the way, you know, you're going to make a few mistakes, and you know, the best thing to do is to learn from those mistakes. And if you do, you know what, just put your hands up and say, hey, we made a mistake. So thanks for listening. That's a brief talk about how hopefully you can get some energy and social movement in the work that you're about to proceed on. Thanks very much.
Thanks, Pete.
Thank you. Sorry, Nick, over to you.
Thanks, Andrew. Thanks, Pete. No, that's great. So just bringing us towards the close, and before we go back to our last Q&A panel, and thank you to the, well, still over 100 people on the call, so that's absolutely brilliant that you're still here this late in the afternoon, so thank you very much. We're going to just go back to Mentimeter for a last time, just to capture some more thoughts around some of the things we've just heard, particularly around quality improvement and measurement, and then particularly, you know, where you think our support may be helpful. So again, if you've got your phones at hand, you may already be logged in, or you may need to log back in again. Again, scan the code, and we'll get logged in. So the first question we want to sort of pick up on with you is, this is something we've talked about quite a lot, about measurement. So Chris touched on measurement. I talked about measurement in the model for improvement. What do you think are the right measures when we're thinking about ward rounds and the improving ward rounds? What do you think are the right measures that we should be thinking about? And there's no right or wrong answer on this one. This is a genuine open interest in, because we've had this debate internally within our team, and we said, well, we'll put it out there, put it to the team, put it to you guys. What do you think is the right measure? So yeah, lots of patient experience. So value add days, I guess we're talking about, you know, the red and green day concept as well. Yeah, lots of patient experience.
Yeah,
reducing
person-centeredness is really coming through.
You can put as many as you like on here. It's not down to one. This should just scroll through. Nurse presence, yeah. If you want a nurse on a ward round, then count how many times a nurse is on a ward round. Simple stuff. Some of the measurements you may just have to do manually. We can sometimes restrict ourselves by what data is available to us, and we don't think what we have to collect manually. How many rings to answer the? I'm assuming that's going to be call bell. Or the phone. Okay. So these are all the things I want you to sort of think about. One of the things I think it was Pete actually that mentioned it from a consultant who talked about the turnaround of test results, for example, would have an impact on the ward processes, you know, and how that influences ward rounds and patient experience. So yeah, general reduction in length of stay, lots of patient experience. So staff feedback. I think staff's really important as well. What does it feel like for the team? Do they feel like it's an easy process? Does the ward round, is it inclusive? Does it feel like it's in the hands of the few rather than the whole MDT? So yeah, getting staff feedback. So these are all things to think about. Okay, that's really, really helpful. I'm still getting lots of engagement, so thank you. Over 100 of you have commented on this. Time it takes to, is it reduction patient? Yeah, time it takes to actually do it. Yeah, we spend a lot of time on ward rounds. Is it all value adding time? Not sure. Okay, so we're going to move on to the next question.
Thanks, Nick. Okay, so the next question is really thinking about how we support you That's right. Thanks, Nick. I thought we jumped one there. Where are we?
It's all gone a little bit, bit late in the day. It's all gone a bit wrong. There you go.
That's absolutely fine. So, having heard everything that we've heard so far today in the session, what do you feel are your current biggest challenges in terms of the collaborative and modern ward rounds going forward? So what are your challenges at the moment? And that'll really help us to really frame our support to you. Okay, staff participation. Yeah, getting buy-in, getting people involved. Okay, the practical aspects again coming through around time. Okay, engagement a lot. Nurse confidence. Okay, tech. I think that is one we do need to look at, which will be great. Okay.
Yeah, the staffing levels, there's thing about staffing levels there as well, and staff engagement. I think there's something about where we look to do something different. Is that going to increase the resource burden, or is it going to reduce the burden a bit later on in the day? What we find often is, particularly on nurses attending ward rounds, is that by investing the time early on in the process, it relieves time later on in the day when you're trying to get caught up. So when you're looking at staffing time and staffing availability, is that staffing time and staff availability always in the right place at the right time?
And it's not just nursing, is it, Nick? I know Gordon earlier was talking about cleaning times, meal times, all of those things as well. So it's all the things that happen on a ward on a daily basis.
Yeah, a lot happens in the morning, doesn't it? It's like everything that's happening in the morning. And does it really? Okay, thanks for that, everybody. I'm going to move us on to the next question.
Okay. Oh, so people have started answering already, which is great. So it's thinking about the ECIST support. So we want this to be slightly different to what we would normally do as an ECIST assignment. So what ECIST support would you find most helpful during this collaborative? You know, the check and challenge, peer support, peer review. What is it that we can do to help you? Okay. So ways to implement change and quality improvements. Yeah, the QI methodology to staff who don't know it. Absolutely, we can cover those aspects. Engagement again is coming through. The external eyes probably. Support, check and challenge, peer review. Yeah, peer review, QI resources, coaching. Fantastic.
Part of our ethos here is that we want to be helpful. This is not about putting on a collaborative and mandating to you what you do. It's not a, you know, it's not a prescribed approach. We want to be helpful, so it's what you think will be helpful, and what we don't want to come across as being prescriptive in how we approach this. So all this is really good peer support. You know, networking. We can put you in touch with other people. Always helpful. So again, reach out to your coaches as they reach out to you, and your links. Every organisation has a QI coach and an improvement manager linked to them. So make sure you connect with those and make the most of that.
That's a great response. Thank you.
Brilliant. So again, moving us on to the next question, which is often a bit more of a strange question.
But really, on the flip side, what do you not need from ECIST? What are the things that you don't want us to be doing to support you? Bit of an odd question. Patronise, yeah. Let's hope we don't. Yeah, and we're certainly not there to criticise, absolutely. Yeah, dictate, giving you orders, time deadlines, yeah, all the things that we aim not to do. Yeah.
One of the things we talked about as a faculty, and you'll pick this up from your coaches and your links, is that our relationship is with you as ward teams. Often our ECIST engagements sometimes may be with, we may check in with chief operating officers, directors of nursing, medical directors, directors of ops, chief executives. That's not what this collaborative is about. We're not going to be going back and saying to people, oh, you know what they're doing down there, you know what they're not doing. Our relationship is with you as a ward team, and that's the connection.
Yeah, unachievable aims, unacceptable expectations, long meetings.
It's
Yeah.
the last long meeting that you have.
Yeah.
Sorry,
Sorry.
we needed it. We needed it there. Okay. I'm going to move us on to, that's a helpful little prompt, to the last question of the session on the Mentimeter. And so thinking about, as we leave today, and as you go back to your organisations and go back to work tomorrow morning, maybe after we finish this session, what's the one thing you can do now? Think about those plan, do, study, act cycles, the simple tests of change that you can apply in your areas without any asking for permission, without asking for writing any plans or getting any great consensus. What's the one thing that you can start to do when you go back? Develop those simple things, like when you develop ideas. Sometimes it's as simple as sticking up a piece of flip chart paper in the ward office or wherever you can and just asking people. It's not a suggestion box. It's getting people to write things down and just get them up on a flip chart just to get things started. Something as simple as that.
Yeah, stir the curiosity of the team, and hopefully some of that started with the self-assessment. I think that's a really good starting point for that.
Yeah, and everybody should know what their self-assessment is. Yeah. Share that with your teams. Give them the aim. We talk about what's the aim, what's the change you're trying to make here, what's our sense of purpose that Pete talked about. Yeah, so lots of team engagement here. This is really good. Doesn't feel like there's people going to go away and do to people. We're going to implement this new idea. There's lots of engagement with the team. Communication is really important. It's worth taking your time on this as well. I think you've got the right idea here. It's worth taking your time to prepare the ground, prepare the foundation before you start. As I said, we'll share all these. There's some great outputs from Mentimeter, so we'll share all these with you after the session, and probably sometime tomorrow morning. Okay, I'm going to let that run in the background, and I'm just going to, so I'll stop sharing now. And I think, so we're going to hand back over to Dan and Andrew. We're going to lead a short Q&A session. I think Wendy's on the chat room as well. If there's any questions that you want to ask the team, any kind of, as we wrap things up, put any questions in the chat box, or put your hands up if you want to ask any questions directly. We will hang around. Anything to do with the quality improvement session that you've heard this afternoon, anything related to the morning session around the ward round collaborative process, or the guidance, or the breakthrough series collaborative model, please put your hands up or ask any questions in the chat room at home. Dan, over to you.
Thanks, Nick, and thanks to all our QI speakers. I always feel really small when Chris presents on data. I feel I like data, but whenever Chris presents, I always feel like I'm just so ignorant about SPC charts and data. And I also, after Pete presented today, I feel really ignorant about my PowerPoint skills. So much interactivity, I need to steal some of those ideas. So while we're waiting for a couple of questions to come through in the chat box, I'm just going to ask a couple of questions myself with Chair's prerogative. Vince, fantastic talk you gave today, and really, really powerful. You presented lots of different things, lots of different methodology about QI, and I'm conscious we've got 16 different teams on the call. All of them might have got different ideas about preferences to methodology. What's your thoughts on that? I know you've obviously presented the PDSA cycle, the change model, but what's your thoughts about the fact we're working with different teams, all utilising different QI models, all with different levels of experience?
Yeah, I think it probably goes back to a point Pete made around just keep things simple. So I think if you've got access to QI experience in your organisation, certainly draw on it. If you've got QI experience and you've got something you know that's worked in the past, certainly draw on that as well. But, you know, just keep things simple. Don't try to test too many changes at one time. Start small. Experiment with the tools. You know, as Pete was saying, you know, don't be afraid to fail. So I think, you know, we don't want to be prescriptive with the collaborative. But you do need a few tools if you want to test quality improvement. But my advice to people would be, seek out the experience in your organisation, tap into the QI coaches, join the QI sessions, and find something that works for you and your team.
Thank you, Vince. And I'll move on to Pete. Pete, great presentation. I said I was really impressed by all of the interactivity. It was really powerful. Some really good comments in the chat box to say that we should have had you maybe earlier in the session just to kind of stimulate everyone's thinking. Pete, can I just ask, in the current climate where we're all working virtually, do you think that that kind of influencing and creating a movement, is that harder or easier in the current climate?
Pete's just jumped onto another call, but I'll pick that up if you want.
Of course, Nick, that'd be great.
I think it is harder. One of the things we do lose we all, as human beings, we're all social creatures. We do lose that connectivity. It's how we find ways around that. We all just have to accept that it's not the same as being in the same room with each other, having a coffee. But having a virtual coffee is becoming popular as well. It's coming together in different ways. So it's not as easy as it was, but it's not completely been abandoned. You still definitely can do things remotely. It just takes a little bit more work, a little bit more time to embed the kind of psychological safety that you'd get by working together face to face. It just takes a little bit longer, but don't be disheartened by it. It does come.
Thanks, Nick. That's great. I'll hand over to Andy and Wendy. Is there any questions from the Q&A you'd like to put to our speakers?
So, thank you, Dan. We haven't had anything come through specifically. Richard and Stephen, two of the clinical associates from ECIST, have started their own debate about the nomenclature around the term ward round. And I guess I'm sure John and Nikki won't mind me sharing this nugget, but when we actually met for the first time as a working group, there was agreement in the room that actually the term ward round was probably not fit for purpose, but we couldn't really publish an updated guidance suggesting the word ward round wasn't fit for purpose. What is apparent and clear is that actually ward rounds are how hospitals do most of their business most of the time. And whilst the term ward round may seem a bit antiquated, the principles of how we do our business actually haven't changed a great deal, and it's about going back to doing them well and needing to innovate and do them differently to bring them up to speed rather than necessarily changing the nomenclature. And the guidance was pretty clear in acknowledging that a ward round on a stroke unit would look different to a ward round on an acute medical unit, which would look different to a surgical ward round, but the principles behind all of them would be the same. So that's a very long-winded way of saying there aren't any questions in the chat room, but also it's also made me think. So my reflections from this afternoon is I think we should have a Twitter debate. So I'm looking to Dan and colleagues and Nick and others. So I think we should have a Twitter debate on whether we believe ward rounds are modern, should be modernised, or should be just totally thrown out and do something totally different. So there we go. That's work in progress. Wendy, was there anything that you wanted to bring up from earlier?
No, I think it's been really useful, the chat, lots of people asking questions and other people answering questions. So it's been a really useful conversation. So I think one of the key things for participants to get from this is that we're working with you on the wards, and this is the bottom-up approach. We're not working with your executive teams. I mean, if the executive team members are on the call, that's lovely, but we want to work with you on the wards. And hopefully that's come across well today. But thank you for all of the comments and helpful tips people put into the chat box.
That's great. Thank you very much, Wendy. I'm aware that some people are beginning to dial off. I'm also very conscious that we had an amazing turnout in the middle of half term. So I'm going to give everyone back the gift of time. Like that's in my gift. I think we should probably wrap up earlier than anticipated. And so I'm just going to close, if that's okay. I'd like to start by thanking all our speakers I think we've had a really high quality afternoon. I've learned lots, and I've learned lots in the chat as well. Today has really just been an introduction and a launch. We've hopefully offered a flavour of what's to come, but this is the start of our journey together. I can't emphasise my thanks strongly enough to the members of the steering group who have been working tirelessly behind the scenes. So thank you all very much. You've just been amazing and continue to be amazing. And they will be there supporting us all throughout the collaborative. And my final thank you is to everyone who's dialed in today and participated. The chat has been absolutely fantastic. There's loads of really rich conversations that we'll need to go through and curate. We have recorded this, so it will be available. We will share the link to the Futures platform. We will set up some WhatsApp group for people to join should they wish. And I am going to get into a Twitter debate. I've got quite excited about it. I've got no idea what it means or how it worked, but I'm quite intrigued. I think it will generate quite a lot of interest. And so our next event in the collaborative is on the 17th of June. It's the first QI learning event, and our first clinical event is a week after on the 24th of June. If you haven't already done so, please can you work with your teams and complete your self-assessment and send them back to Crystal on the generic email address, if that's okay. So for those of you who haven't had a chance to meet your QI coaches yet, we will be in touch. I know that I haven't touched base with one of my sites, but we will all be in touch within the next 7 days, and we're all very much looking forward to working with you on this. Thank you all for your enthusiasm and energy. It's been amazing. I'm totally inspired, genuinely totally inspired. I'm really looking forward to everything and working with you. So thank you all very much. If you're traveling, have a safe journey home, and we look forward to seeing you on the 17th of June. Take care now. Bye now.